We're going to talk about safety today. These are our objectives. We want to define the concept of safety, discuss personal environmental factors that impair a client's ability to protect themselves from injury, review interventions that can assist in reducing the risk of client injury, communicate client information to the appropriate team members, discuss how proper and effective use of technology and standardized policies and procedures support safe quality care, recognize the role of the nurse in monitoring their own care and that of others, review the national client safety goals developed by the Joint Commission and their relationship to the development of national safety standards and accreditation of healthcare facilities or institutions, relate the importance of knowing the location and the purpose of the MSDS manual, describe the RACE acronym and use as a guide for action during a fire. The definition of safety is it consists of measures that prevent accidents or unintentional injuries. Many hospital deaths and injuries are due to medication errors, adverse medication effects, infections, and surgical errors. The British Medical Journal in 2016 declared medical errors to be the third leading cause of death in the United States, just behind heart disease and cancer. That is embarrassing. The National Patient Safety Goals were established by the Joint Commission. That started in 2003, and they're updated periodically based on recommendations of the Patient Safety Advisory Group. It was last updated in 2020. Revised regularly to reduce the incidence of death and injuries among clients receiving care in healthcare agencies. Adherence to these goals are priority and must be demonstrated by healthcare organizations in order to obtain and to retain their accreditation. Remember, if they lose accreditation, Medicare and Medicaid quits paying. And when Medicaid and Medicare quit paying, the other insurance also follows suit. So for reimbursement purposes, they want to keep that accreditation. Remember to observe the patient rights of medication administration every time you go to pass medications, even if you've seen that patient all day long. When you go to pass meds, you need to observe those patient rights of medication administration. It's just a really good habit to get into. It'll save you and your clients a lot of problems. Some things to be aware of that are biohazards. Oh, and I spelled biohazards wrong. There should only be one Z. A biologic agent, chemical, or condition that can be harmful to a person's health. The Occupational Safety and Health Administration, OSHA, I'm sure you've heard of OSHA, classifies material in the work environment according to the degree of hazard to the health that they may impose. OSHA publishes specific guidelines for labeling, handling, cleaning spills, and disposing of these materials. This is kept in a MSDS, a Material Safety Data Sheet. Every facility accredited by the Joint Commission has to have an MSDS for OSHA as well as Joint Commission. These manuals are consulted for recommended methods of storage, labeling, handling of spills, and disposal. There should be an MSDS sheet, MSDS for each biohazard substance stored or used in the nursing unit. Just as a crazy example, even lotion that we had set out on the nurses station had to have an MSDS sheet on it that was in our policy and procedure manuals room, because if you got it in your eye or in a wound, how do you clean it? How do you store it? Everything in the facilities have to have an MSDS sheet. Another environmental hazard in the healthcare facilities, radiation, X-ray, CAT scan, MRIs. Radiation, a form of energy that can come from manufactured sources as well as the sun and outer space. We're always exposed to a little bit of radiation. Nuclear energy is a dangerous manufactured source. Medical radiation is used for X-ray imagery, and radiation is used for treatment of tumors and cancer. Someone that has an overexposure to radiation or acute radiation sickness has experienced a high dose of radiation exposure over a short period of time. The symptoms are nausea, vomiting, diarrhea, loss of appetite. They could have seizures, coma, and eventually death. The only safe thing to help with preventing radiation sickness is the protection of time, distance, and shielding. So as you know, we are going to be exposed to radiation when our clients need to be helped into a position for x-rays, or maybe you're in the room when they're doing some kind of a C-arm x-ray or something. You're getting a small dose of radiation each and every time that happens. They may hand you an apron and you are to cover yourself so you don't get repeated exposure over and over again that can build up in your system. Radiology techs or radiology staff have to wear a monitor that clips onto their apron, that it's a dosimeter. I can't say that, dosimeter that tells how much radiation they've been exposed to over a period of time. And if it's too much, then that they have to avoid being around it for a while. No age group is immune from accident or injury. Distinct differences exist between age groups on levels of cognitive function and judgment, activity level, and mobility. The degree of supervision, the safety devices used, and the design of the environment also affect the safety of clients and staff. Infants, of course, are fairly helpless, and they run the risk of falling off of a bed or a changing table when their diapers are being changed. Unrestrained in automobiles. I kid you not, I remember my little brother going home from the hospital with my mom, and we carried him in a laundry basket. I know that sounds crazy, but that was back in the 70s, and we don't do that anymore. Kids do not leave the hospital unless they have an approved restraint seat for them to leave in. Toddlers, once they get up and moving on their own, they're even more dangerous. Then they're climbing and they're mobile. They may they put everything in their mouth, accidental poisoning. Falling, again, is also a thing. Burns. Cooking on the stove and that handle sticking out, they could reach up and dump that hot liquid or food right on them. Even, for taking something out of the microwave and it dumps and it spills hot liquid on them. Electrocution. Kids are famous for wanting to stick little forks and spoons into those outlets. Drowning. Never leave a toddler unattended around water or in the bathtub, even if it's just a little bit of water. They can do crazy things and drown. School-age children and adolescents, now they're getting bigger. However, they have play-related injuries. They're pretty active. Adolescents, they do a lot of sports. They could have sports-related injuries. And then they also have the peer pressure. They're pressured to take risks that they don't have that. They lack that judgment that they should really have as adults. Their brains are not fully developed, and that peer pressure causes them to get involved in risks that they really shouldn't be taking. Adults also ignore safety issues. They could have fatigue, especially when driving, sensory changes as they age, effects of disease. And then the elderly, of course, have their own population with injuries and challenges all their own. There are some environmental hazards that we're going to talk about. This is not all-inclusive by any means. It's just kind of a grouping. We've got poisoning, asphyxiation, smoke inhalation, carbon monoxide poisoning, latex allergies, thermal burns, electrical shock, falls. Poison is a substance when ingested, inhaled, absorbed, applied, injected, or developed within the body can cause functional or structural disturbances. Treatments and antidotes obtained from a poison control center are listed on some containers. In the event of a suspected poisoning, contact Poison Control Center. They have the label of the product that you think was ingested in front of you and be ready to report. You want to know the name of the product, the patient or client's age that ingested the substance, the amount you believe they ingested, and any symptoms involved. Asphyxiation, that just means the inability to breathe. Whether that's a plastic bag that a toddler's playing with and they get over their head and they suffocate, or, smoke inhalation, drowning, inhalation of noxious gases, or carbon monoxide. Fires create gases, and superheated gases, if you inhale it, can actually burn the respiratory tract or the airway, causing swelling or impair that airway to where they can't take air through their airway anymore. Carboxyhemoglobin. That is carbon monoxide combined with hemoglobin. It combines with the hemoglobin molecules instead of the oxygen combining to the hemoglobin molecules. This deprives the brain and other organs of the oxygen needed. Remember, oxygen is transported by hemoglobin, so if carbon monoxide adheres to those molecules, you've got carboxyhemoglobin instead of oxygen being carried by the hemoglobin. That will cause your cells, especially your brain and your heart, to be oxygen starved. Carbon monoxide poisoning is odorless, colorless, tasteless, and it is an invisible poison. Burning fossil fuels in a small room, an unvented area, or enclosed area allows for the buildup of this deadly gas. I don't know if you've ever seen or heard of someone that committed suicide by turning the car on, either accidentally or on purpose, with the garage door down and just sitting in the car running in the garage when it's all closed up. Symptoms of this carbon monoxide poisoning are kind of flu-like at first. It starts with vomiting, headache, weakness, confusion. Then as it builds up, it leads to unconsciousness and eventually death. Even if the person survives after a major exposure, they could suffer some brain damage because of that lack of oxygen, and it depends on how long that goes on. A classic sign of the carbon monoxide poisoning is that bright cherry red skin coloration. This persists even after death. It's a very noticeable bright cherry red color. Here is now you can't click on this when you're just watching the video, but if you go through the PowerPoint with the notes, you can do that control and click, and this link will take you to a fire safety video. You need to know and be familiar with your institution's fire regulations. Smoking in open flames are almost always banned in most healthcare facilities. Some long-term care agencies allow smoking in designated areas. Some of our elderly do still smoke. It's getting to be less and less people that smoke as a habit, but there are some. And in the long-term care facilities, there are a few exceptions, but more and more they're just non-smoking. If you do have a patient that wants to smoke and is sedated or confused or irrational, you have to very carefully supervise. Smoking is never allowed when oxygen is in use because even a spark could cause a fire. Any equipment that might cause a spark is also prohibited near oxygen. Know the location of the fire extinguishers, the fire alarms, the escape routes, and how to notify the telephone operator of a fire in your area. There are 4 types of extinguishers. A is just water under pressure. It's used for things that burn like paper, wood, cloth. Type B contains CO2. This is used for gasoline, oil, paint, flammable liquids. Type C is used for electrical fires, and type ABC can be used on anything. So here's, again, this link. If you are not watching the video, if you're just doing the PowerPoint with the PowerPoint slides with the narrative notes at the bottom, you can click on this link. An acronym you need to know is RACE. It doesn't matter which facility you work in. All of them require that you know this. Rescue, alarm, contain, and extinguish. So first you rescue any patients that are immediately in danger. If a patient is smoking in bed and they catch their blankets on fire or some kind of medical equipment causes a fire and that patient's bed is on fire, you want to rescue that patient. Then activate the alarm. Then you pull the alarm. Contain the fire by closing doors and windows, depriving that area of oxygen. You can take a damp towel and put along the bottom of the door after everybody's rescued out of that room. Extinguish flames with an appropriate extinguisher. That is the last thing you want to do, is try to extinguish the fire. PASS stands for pull, aim, squeeze, and sweep. You pull the pin on the fire extinguisher so that you can squeeze the handle. You aim it at the base of the flame. You squeeze and you sweep across to get the entire flame. So RACE and PASS are acronyms that you're going to need to know. Hint, hint. Latex sensitivity, latex allergies. A sensitization is an allergic response to the proteins in the latex, a natural rubber sap from the tree it's a tree in Brazil. And this chemical substance is found in lots of household things like balloons, the elastic in your underwear, erasers, carpet backing, envelope glue. The list goes on and on. It's in a lot of things. But some people are very sensitized to this. Health-related sensitization can be the result of repeated exposure to latex, people that have had a lot of surgeries, or even healthcare workers themselves. Now, keep in mind, there's also a lot of healthcare workers that thought they were allergic to latex and come to find out they were just allergic to the powder that used to be in the gloves. I almost never see that powder in the gloves anymore, but it is still possible to get a sensitization to latex with repeated use of latex gloves. There may be a predisposition to latex sensitivity with those that have a history of asthma. Sensitized people can develop a cross-reaction to certain fruits and vegetables. If somebody knows that they're allergic to kiwi fruit, bananas, avocados, something like that, you can assume that they're going to be allergic to latex as well. There's some kind of crossover in that sensitization. Two forms of allergic reaction. There's contact dermatitis, which is just a localized reaction, just an irritation, inflammation of the skin on the hands that come into contact with the latex. It can be a delayed reaction. It could be 6 to 48 hours after exposure. An acute hypersensitivity, this is the dangerous one. It's an almost immediate systemic reaction that causes swelling, itching, respiratory distress. It could even drop their blood pressure, hypotension, and could be severe enough to cause them to have death if they cannot breathe. Falls. Okay, 3 common factors could be impaired physical mobility, impaired mental status, sensory and or motor deficits. Assess all of your elderly patients for fall risk. Most common accident with the most serious consequence in older adults. That's probably going to come up again. Contributing factors: visual impairments, disorders that affect their gait, balance, and coordination. Medications. All the older adults, so many of them are on things to lower their blood pressure. This is a risk factor. You're going to be screening your patients, your clients, for fall risk, especially the elderly, on a regular basis. Ways to prevent: ambulatory devices if they need it, canes, walkers, assisting the patient to the bathroom, remind them to call for assistance, up to the chair, keeping the call light within reach and reminding them to use that call light. Assess for fall risks in the home. If they're going home, do they have a lot of throw rugs, pets, little pets that run under their feet, extension cords, even furniture, or stairs without rails? Burns are another problem. Prevention includes protecting the patient from thermal injury that can be caused by hot or cold materials. You can actually have a freezer burn. People that have sprained their ankle and you want to put a cold pack on that ankle, you want to keep something between that bare skin and that cold ice pack. You don't want to frostbite them. And the same is true of hot. If they're needing warm packs, you don't want to put something directly on their skin, especially if they have some kind of a sensation impairment. What if they're diabetic or neuropathy of some kind and they can't feel that limb, then you don't want to put something against their skin directly or leave it for a long period of time and they go to sleep or something, and then it causes a burn. Diabetic patients, paralyzed patients, patients with altered mental awareness. You need to check the temperature of the liquid before giving them to patients, whether that's something to drink or a bathtub. The nurse should caution the patient about sleeping on a heating pad. I know sometimes they're cold all the time and they love those heat blankets, but that can be very dangerous, especially when they go to sleep. They have decreased sensation or level of consciousness and they overdo it. They can burn themselves. Electrical shock. you need to be inspecting those electrical cords for frayed or broken areas. If you are using some kind of medical equipment and you see that it's frayed or broken, that needs to be taken out of service and flagged for the people to fix. Shock can occur from improper use of hospital electrical equipment. Do not use extension cords. Macro shock is the harmless distribution of a low amperage electricity over a large area of the body. It may just cause a little tingling. A micro shock, believe it or not, is actually more dangerous. It is low voltage but high amperage. So it may not be felt, but it can be fatal. If your skin is not intact or it's direct to the heart or the skin is wet, that can cause a microshock to be fatal. And I don't think I included this on the slide, but grounding, there's a grounding prong on the plug. You know how plug-ins have 3 prongs. The 2 that are complete the circuit, and then that 3rd prong is a ground. In case there's a stray electrical current, it takes it down to the ground and away from the client. Don't ever use a plug-in that the prongs have been cut off. Sometimes people cut that 3rd prong off to make it fit in the plug-ins. The old-fashioned plug-ins only had 2 openings. Okay, restraints. We have talked at length about restraints in the legal and ethical video. You can go back to that and refer to that if you'd like. This is just kind of a brief synopsis, but I would encourage you to go back and look at that. Physical, wrist, limb, or vest restraints, chemical restraints or medications, can be in a psychiatric setting, a sudden change in mental status or behavior. Non-behavioral indications could be using continuation of medical treatment. If they're trying to do IV therapy and they keep pulling it out, or catheters, maybe a child that needs sutures may be temporarily restrained by an adult. Legal and ethical considerations. Federal and local laws mandate that you protect the patient from physical and mental abuse, from physical and chemical restraints. They should never be used as a convenience for the staff. There has to be a written order by the physician in writing for a specified and limited period of time. Every 24 hours, that has to be reevaluated. And they have to be discontinued as soon as possible. You can go ahead and use them in an emergency situation, but you get that doctor's order right away. The Joint Commission supports the use of protective devices if clinically necessary, but only as a last resort. The goal is to move to a less restrictive environment. You want to move them to a less restrictive alternative, if at all possible. Get them closer to the nurse's station. Use one of those devices that sounds an alarm when it pulls loose from the magnetic part that sticks to the bed. Alternatives. Healthcare workers are encouraged to find alternatives to the use of these protective devices. Family and friends of a patient who is confused can be encouraged to sit with the client and promote the safety. High-risk patients should be in a room close to the nurse's station. Be sure the call light is within reach and they can use it. Stay with the confused or unsteady patient when they're up and moving. Provide diversionary activities for the confused patients. Make sure wheelchair brakes are locked. Use the least amount of immobilization needed. For restrictive devices, there must be a written order. As soon as the device is no longer needed, the physician is notified. Apply the device snugly but not too tight so as to interfere with the blood circulation or nerve function. The device must be removed and the patient's position changed every 2 hours, active or passive range of motion. It is your responsibility to be aware and follow the regulations in your facility and area. And I don't think it's on here, but remember you need to be offering fluids and offering the bathroom frequently. There's also a link in this to a video here on this slide. Good communication is key. Involve all the disciplines to watch out for those clients that are fall risks. Code signs on the door sometimes you'll see like a tree or a leaf or a yellow star, yellow footy socks with those non-skid bottoms. Those are fall risk flags that it's to help visually alert all the staff without saying fall risk all over the place. It's kind of a coded sign that everybody needs to know about to help watch out for those folks that may need to be monitored. Allergy bracelets should be worn in the hospital or outpatient clinics. Computerized assisted alerts for allergies, drug interactions, and fall risks automatically flag the electronic chart. This is so wonderful. So you're going to give some kind of a medication, an electronic flag will pop up. You know, what's the patient's blood pressure now? This patient is allergic to, remember, this patient's allergic to whatever they're allergic to. If you're going to give them an antibiotic, it'll say to check the allergies again. It's just really nice to have those electronic flags pop up. Lead by example, as nurses we're expected to know how to keep ourselves healthy as well as our clients, diet, exercise, just using seat belts and safety precautions that are expected of everyone, and healthy lifestyle choices. Here's our safety unit objectives again. Hopefully we've hit all the high notes here. Please take time to watch those video links that are included, and have a great day.